afternoon to the UK and good evening to India. Very warm welcome to our next webinar, which is a joint webinar between the UK Society, LSGBI, and also IHS. And I'm very happy that we have had such a rich audience last time. It will be very short this time as well, which will be the topic on the colorectal surgery and namely on the anastomotic leak. I would like to pass my words to Ms. Shafak Sheikh, who is a colorectal and robotic surgeon and also the LGBI Council member. And many thanks for joining us today.
Thank you very much, Dana, and warm welcome to everyone across the world, actually, probably not just India and the UK, because it's far-reaching in terms of the reputation of this webinar series. And of course, the topic for today is quite a sensitive one that's close to the hearts of all colorectal surgeons, anastomotic leak in colorectal surgery. And I suppose, we take it all very personally when a leak does happen, but there are numerous factors that contribute to leaks happening, and that's what we have presented for you, hopefully, through the course of some very rich discussions and presentations. So without further ado, I would like to invite Professor Selva Sekar, the newly appointed president of ALRS GBI. As you know, that our society is now incorporated robotic surgery into its name. Professor Selva Sekar, please, for your welcome message.
Thank you, Shafak. Thank you, everyone. Welcome to this ALS, ALRS, GBI, and IAGS webinar series on anastomotic leak. I think it is this webinar series has been running for the last 2 to 3 years, and it has improved based on the feedback from the colleagues. So please give your feedback at the end, or put your questions and comments on the chat. This has been a fantastic initiative, and over the years it has matured very well. I'm a colorectal surgeon based at the Christie in Manchester. Over the next hour or so, you will hear about how to prevent and also deal with anastomotic leak from both sides of the from both the societies, and see whether there's any shared learning, and also see how we can improve our practice going forward. If there are any other topics for discussion you would like to bring as delegates, please put that on the feedback. We'll be delighted to consider. And I would like to thank the team, both from UK and from India, who do a fantastic work, because what you see is just an output from weeks of work which goes on behind the scenes. So thank you, everyone, for doing an excellent work and for participation today. And I hope we can see you in Manchester next year for the ALRS GBI annual meeting. Good luck. Thank you.
Thank you, Professor Selva Sekar. And I'd also like to invite Mr. Graham Whitley, who is a council member of the ALRS GBI, for a few words, please. Thank you, Graham.
Well, welcome everybody to this afternoon in UK and evening's webinar. I'm halfway between the two of you. I'm in East Africa at the moment. I'm looking forward to the subject of this webinar, anastomotic leaks for colorectal surgeons. Yes, everybody regards it as a potential disaster if you have a leak, but we should all be open and discuss why it happens, how we can prevent it, and I'm very interested in what the speakers have to say today. So thank you, Shafak, and thank you from a new name society, the ALRS GBI, and a new president, Sekar. Thank you. Back to you, Shafak.
Thank you very much. It'll take a little bit of practice, but it'll come easy. And over to Kanagavel now from the IHS. Thank you, Kanagavel.
Thank you, Shafak. And it's been a great journey together with the British friends, colleagues, and then Indian colleagues. And I have a couple of announcements before we start the program. Friends, we are going to have an endocrine update for the January session. So please stand by for the information so that you all can block the dates and be with us. So it's going to be a lot of thyroids and a lot of adrenals to be discussed for the January meeting. So look forward for the information. This is number one. And on behalf of the IAGS, and we all warmly welcome all of your colleagues today in this forum and the forum across the world to visit our upcoming international meeting coming in the month of February, second week, the IAGS ELSA Collaborative Annual Conference. So we'll be happy to host those who are interested. Please reach one of us to our office. We'll be glad to host all of you in our program. With that few words, I warmly welcome our president, who's been always the go man for academics, and he never says no for any of our programs. And he very carefully scrutinizes and keeps a close follow-up of activities. So let us welcome Professor Satish Mehta. He is one of the very dynamic person who keeps traveling irrespective of the time and date for the cause of academics. So Mehta sir, we'd like to hear from you. Thank you.
Good evening, good afternoon, and maybe good morning in some parts of where from the delegates are lodging. And welcome on behalf of IAGS family. And congratulations, Dr. Silvasekar, for taking over of president of ALR SGBI. So, anastomotic leak is very important topic, and we have now various techniques and technologies, including ICC and many more things. And we want to bring it to zero, but we have not been able to bring it to zero. So we have few cases which may be nightmare for patient as well as for surgeon. Anyway, we have to keep on improving. Hope speakers from both sides, Dana, Matin, Patel, Padawan, and Dr. Anil Herur will give an insight into this. We also welcome our past president, Dr. Ishwar Murthy, who will be moderating, and Dr. Shafaq also. So welcome everybody, Dr. Graham, Marina, and we will continue with the academics without wasting much of time. Thank you very much.
Thank you, President. I think we are ready to go with an academics now, and in tune with today's topic of the day, the colorectal anastomosis and the problem with anastomotic leak. We have our opening batsman, none other than our Dr. Anil Harur from city of Mumbai. So he is a oncological surgeon and a robotic surgeon, currently practicing at KIMS Hospital, Thane. And he is one of the pillar of our IAGS in all academic activities, because he drafts all our academic program in relation to the advanced oncological and colorectal courses we conduct periodically. And he has an extensive experience. He is actually product of Tata Memorial Hospital. He has done the MCH, following which he traveled across the globe to Sloan Kettering in USA, and also on South Korea, Japan, to get all the tips and tricks. And he is the person, the go-to person for all, even though he has a vast spectrum of oncological experience. His main interest is in colorectal surgery. So he is going to talk on his pearls of wisdom in challenging situations of multi-visceral resection in colorectal surgery. So let us go back to the Anil Herul to hear from him, and then we'll have the discussion. Over to Anil Herul. Thank you.
Greetings, and I'm Dr. Anil Herur, and I'm thankful to ALHGBI and IAGS for giving me this opportunity to talk about an interesting topic, which is multivisceral resection in colon cancer. Now, my first experience as a resident with multivisceral resection in colon cancer was when this patient of obstruction had come to us in Tata Memorial Hospital, and in the wee hours of the early morning, what we did was we resected the colon, the spleen, the distal pancreas, and the kidney, and did a primary anastomosis. The next day, my bosses, Dr. L.J. D'Souza and Dr. Jagannath, as you can see in the photograph, had a wry, sarcastic smile and said that you are now becoming very, very adventurous. So now, when we talk about multivisceral resection in colon cancer, what are the questions that we need to address? The first is obviously, when do we do multivisceral resections? Do some locations do better than others? Will biology play a role? what approach should we take? Should we do minimal access? Should we do open surgery? Should we give neoadjuvant therapy for all? And most importantly, what are the outcomes of this surgery, oncologic as well as functional outcomes? So the first question, when do we do it? We have some guidance in literature for this. This is this huge data of 11,000 patients from the Netherlands, and they have given some pointers on when we can do MVR resection in colon cancers. So obviously these have to be T4 cancers. They are labeled T4. Only then you will require multiviscerals. They should ideally be of good biology. ECOG score or the performance score should be good. The diagnosis should be more recent. Your intent, and that I think is the most important thing, should be curative and not palliative intent. And obviously, the hospital should have a high volume and good surgeon experience. Right-sided tumors, given their poor biology, are less likely to undergo multivisceral resections, and left-sided, obviously, as they present a little earlier because of their obstructive symptoms and because generally the biology is better, do better than right-sided tumors. Now, location wise, as we just mentioned, the left sided tumors are more common, and among them, the sigmoid is the commonest. If you take a gender ratio, 42% of MVRs of females would be in the sigmoid, and 34% would be in males. The most common organ that is resected along with the colon is the small intestine in 30% patients, abdominal wall, and the adnexa or the uterus. Genitourinary tumor organs like the urinary bladder are also rarely resected along with the sigmoid colon. What is the biology of these tumors? Now, most often or not, we see that mucinous tumors have increased local infiltration, and that is why probably in our country we have a little more incidence of MVRs because the patients are going to present late, as well as the fact that a lot of these tumors, nearly 30% of these tumors, are either poorly differentiated or are mucinous or are signets in their history in their histology. Prognosis of MSS, that is microsatellite stable patients, is better than unstable patients. Now, how would you subclassify the multivisceral resection? It is subclassified according to the organ that is removed along with the colon. If it is an additional bowel resection, it also has an implication that your outcomes are going to be a little worse if an extra bowel resection is required. The recurrence, however, is more if your one of the solid organs is resected. For example, if the pancreas, kidney, uterus, liver is resected along with the colon, then the chances of local recurrence are more than it would be if it is a hollow organ. Would you give neoadjuvant treatment in these patients? Now, we know that most of these patients will undergo some kind of neoadjuvant chemotherapy. Generally, radiation is not added unless a solid organ is involved. The results are good. Downstaging has occurred in 40 to 50% of these patients in most studies. Whether they have impacted survival is not very clear, but definitely resections have become more once you give neoadjuvant therapy. The new kid on the block is obviously immunotherapy. Immunotherapy has resulted in much better results as far as the multivisceral resections are concerned. This is obviously in selected patients. These patients have to be DMMR or MSI high or pol mutated. When you give immunotherapy, the PCR outcomes are also very high. So many of these patients actually may go into complete clinical response. One of the literature I reviewed gave a PCR outcome of nearly 95%, and the least was nearly 65%. So that means that we are going to have very good outcomes when these patients can be given immunotherapy when their histology allows us to give. Now, what is the approach that we take? Is minimal access better? So surprisingly, contrary to what we would expect, minimal access surgery is actually better when we in the various studies that have reviewed minimal access versus open. The post-operative complications in minimal access are slightly lesser. In fact, the overall survival tends to be better, and I think this is because the patients, there may be a slight bit of bias here, because remember, all these studies are not randomized; they are mostly reviews, and because they are comparing two different groups which are not matched, the open patients may be of a little worse stage, and that is why the outcomes in those patients might be slightly worse. But what we see here is that overall survival and the disease free survival both are better. We have to take this data with a pinch of salt, because it is limited data. There are only 6 studies. The events are also much lesser. There is lack of randomized data, as I said, and that is why we need to take this with a pinch of salt. And that is obviously reflected across literature. You have some of the studies which say that LAP is actually causes more peritoneal recurrence. It's an independent variable of peritoneal recurrence. Remember, as we discussed, these are mucinous tumors, and a lot of times mucinous tumors do have a propensity of peritoneal spread, and that is why lap sometimes results in more peritoneal recurrence, according to some of the literature published. What are the outcomes in these studies? Now, if you see, whenever MVR has been attempted, more than 90% of them have been R0 resections. What are the indicators of incomplete resections? If you have a poorly differentiated tumor, if there is inexperienced surgeons operating, if there is a bulky node sitting on the vessel, obviously there is the chances of having an incomplete resection are higher. There is a small Indian trial from Northeast India. So and this is a center in Guwahati. They do high volumes, but their results which they have published is an 100% R0 in colon when they have done an MVR. The most important bugbear, what are the complication rates? Obviously, these are very morbid surgeries. They have very high complication rates. If you have a GI MVR, then the chances of having a problem are nearly 50%. And if the 30-day mortality is roughly around 5 to 7% in the colon. There is Indian data which lists the morbidity as nearly 25%. So this varies across organs. If you see, it is, as we discussed, it is the GI. If it's an accompanying GI resection, then the complications tend to be the highest. If it is solid organ, it tend to be the lowest. So lethality of hospital stay is also significantly higher than when no multivisceral resections are done. So overall, it is a morbid procedure. It does have a learning curve, and that is why it has to be done in a center which has good volumes and a good surgical experience. However, once you cross the learning curve, once you cross the initial difficulties of managing post-operative complications, the survivals tend to be very good. Nearly 40% plus survive overall in DFS, disease-free survivals for these patients. Again, what influences this survival is the age of the patient, the margin status of the resection, node positivity, and what is the kind of chemotherapy that these patients have taken. So all these significantly impact the survival as far as a multivisceral resection is concerned. Now, how does this actually impact us at a ground level? So I would like to present one of our patients. Now, this was a very young 28-year-old. She actually had her wedding fixed, and 1 month before the wedding, she developed this severe pain in the abdomen, which necessitated admission. She was diagnosed as intestinal obstruction. The CT scan was done, and that showed this large tumor, as you can see here, which was involving the transverse colon, the hepatic flexure. The transverse colon was dilated. There were air pockets within. It was indenting upon the gastric pylorus, and we felt that the stomach was involved. The biopsy incidentally showed poorly differentiated on colonoscopy. After the colonoscopy, she started passing stools, and that is why we decided to go ahead with neoadjuvant therapy after conserving her obstruction. This was the PET scan. You can see that there was omental stranding, but there was no liver or lung mets. So T4B tumor, luckily not lot of nodes, and that is why we decided to go ahead with chemotherapy. She had a partial response to Folfox, and then we decided to go ahead with surgery. This was the surgery that we did: a right radical hemicolectomy with a distal gastrectomy. You can see the stomach here. This is the liver, this is the stomach, that was the small intestine, that is the colon, and that is a part of the abdominal wall. So all of that was resected. We also did a distal gastrectomy with excision of the small bowel with a Roux-en-Y gastrojejunostomy. Now, this is the histopath, and this is where I come why multivisceral resections should not be abandoned in a haste. It was a well differentiated adenocarcinoma colon. We had negative margins. The involvement of the stomach was inflammatory. It was not infiltration by tumor, which is another good thing for the patient. It was node negative and omentum negative. So, all of that actually gives you an indication that how much neoadjuvant therapy affects, though you may have a CT finding which may suggest a partial response, yet if it is resectable, we must attempt resection because these patients are going to do quite well. So to summarize, multivisceral resection is definitely a feasible option for T4B colon cancer. The morbidity, mortality is high but acceptable given the chances of good survival. Most common approach remains open surgery, and very importantly, volume and experience count in these resections. So thank you very much. I apologize that I am not giving this presentation live because of connectivity issues. And if there are any questions, I would love to answer. Thank you once again to both the organizations for having this wonderful initiative and having a brilliant exchange of ideas across these two countries and these two associations. Thank you once again. And I would take this opportunity to invite you all for the exciting IAGS ELSA conference that we are going to hold in Mumbai in February 2026. It is your conference. You are one of the associated organizations, and we would love to welcome you all there. Thank you very much.
Thank you, Anil, for a wonderful, fabulous, fact-filled presentation. It was really nice to hear from you. And I think we'll have the questions probably at the later part of the discussion. And I request Kanagavel to take it further. Shall we go for our next speaker, Randeep? Kanagavel? Is he on? Kanagavel, are you there?
Yes, Ishwar, I'm there.
All right. Thank you, Randeep. I think it gives immense pleasure for us to welcome Randeep Wadhawan amidst his busy schedule. Actually, he is hosting one of our essential laparoscopic surgery course as of now, the day 2 in Delhi. And he is one of our academic pillar in IAGS. He has served as our advanced laparoscopy board chairman and conducting various courses across the country for along with me when I was a president. And he actually has an immense interest not only in the GA surgery but also in the metabolic robotic surgery. He is one of the trainer of robotic surgeons across the country, and he has been a fellow of American College and also the Edinburgh College, FRCS Edinburgh. I'm very glad to have my friend Randeep Wadhawan to give the presentation. Apart from his role in IAGS, he has been a president of the Aussie, and also he has been the executive member of HSI. And I think he has so many academic credentials onto him, but he is a passionate teacher and trainer also. So we wanted to listen from him in the color-coded surgery or the image-assisted colorectal surgery, how it can minimize the chance of anastomotic leak. Over to you, Randeep.
Thank you so much, Ishwar, for that wonderful and introduction. I mean, I'm honored to be here amongst all of you, and it's actually an honor that ALS GBI has has collaborated with us. And this is a webinar which goes not just to our IGS members, but it also goes to the ALS GBI members. And I'm honored to be here. Thank you very much once again. My talk today is on image-assisted colorectal surgery, how we can change our outcomes in colorectal surgery, how we can improve our outcomes, how we can ensure maybe avoid leaks in colorectal procedures. Uh, we know that colorectal cancer has rapidly increased and has become the third most commonly diagnosed type of cancer, and it is the second leading cause of cancer death. Surgery, we know that remains the gold standard treatment for colon cancer and it is curative in intent. I'm talking about colon cancer here. Totally laparoscopic surgery for colon cancer with intracorporeal anastomosis is obviously less invasive. All the advantages of a minimally invasive surgery with a good post-op recovery and lower complication rates. But anastomotic lead continues to be a Achilles heel in colon surgery, in colorectal surgery, in fact, where the incidence can go anywhere between 3 to 23%. Among most factors, other factors, the important factor continues to be an inadequate anastomotic vascular perfusion, which seems to have a significant impact on healing of the anastomosis and then non-healing leading to leak. So evaluation of an anastomotic vascular perfusion is difficult. Maybe prior to 10 years, 15 years, surgeons' visual judgment of the color change or pulsation of the small blood vessels used to be the only factor, or it used to be the only subjective indication for knowing whether the perfusion is adequate, whether this anastomosis will hold good, will not leak. But today we moved on to having color-coded surgery or immunofluorescence to actually identify and ensure that we have a good anastomosis, which probably should not leak. When we look at rectal surgery, again, we need to look at better quality of life. And with that, multiple enhancements or multiple advancements have taken place, not just in endovision not just in endovision, it has taken place in powered staplers, robotic systems, various robotic platforms. And with that came in the laser fluorescence or indocyanine green dye, which has immense promise, and that is something which has led to easy accessibility, accuracy, and it's cost effective as well, because the cost for this dye, which I've just shown in this photograph, is in our part of the world it's about 1,800 rupees. In pounds, it could be anywhere around let's say 10 pounds or maybe a little more than that, 15 pounds at best, and no more than that. And that's hardly an amount for something which can help in ensuring that the anastomotic leaks decrease. Now, ICG per se is a water-soluble solution which absorbs light between 790 to 800 nm and re-emits that with an excitation wavelength of anywhere between 835 nm. And it's caught in by these endovision cameras, ensuring that this tells you about the perfusion. IV, it can be given. It binds to albumin. It has a very short half-life, about 3 to 5 minutes, and it is cleared by the liver in about 15 to 20 minutes into the bile. It was earlier used for biliary surgery more commonly, but now, of course, it has multiple usage all across GI tract. IV is safe, non-toxic, non-ionizing. Dosage anywhere between 0.2 to 0.5 milligram per kg body weight, but you can extend up to 2 milligram per kg body weight as well. That's the maximum dosage. But ideally, anywhere between 0.2 to 0.5 milligram per kg body weight is an ideal dose which can be given. Now, the role of ICG or immunofluorescence in colorectal surgery, bowel perfusion, that's what we're going to be discussing today. Anastomotic perfusion before and after procedure, gracilis muscle perfusion, which can be done if you're actually repairing the sphincter, anal advancement flap perfusion, pedicle omentoplasty, where the perineum is where you require to move the the omentum onto the perineum if it's a perineum which is non-vascularized. Urethral visualization, we'll show that how it can be used. Urethral visualization, nerve assessment, then tumor localization by lymphatic mapping, sentinel node, lateral pelvic node dissection, distant metastasis, particularly peritoneal as well as liver. So it has application in all these, and we'll see where we are today as on 2025 and what we intend doing going forwards. So let's look at a short video. So if you're doing a rectal surgery, you would need to know where the perfusion is, both for the rectal stump as well as for the descending colon, which needs to be mobilized and needs to be anastomosed. If you do a perfusion at that time, uh, now the details or the studies completely tell you a different story, but by and large it says that the camera should be anywhere between 5 to 10 centimeters from the organ to actually see for the perfusion. The ideal time could be for a rectal surgery, it could be ideal time to see the perfusion should be no more than about 40 seconds to a minute. Some studies say you can go up to 3 to 5 minutes also if you're looking at colonic perfusion, but for rectal, they say anywhere around 40 seconds to a minute. And the distance of the camera needs to be anywhere between 5 centimeters to 10 centimeters from the target organ. You map this, and once you map it, then after that, you do the resection, ensuring that the colon or the rectum is completely has a vascular perfusion, and then you can do the resection. You can do again a study right after you've done the anastomosis, just to see that both the distal and the proximal bowel where you've done the anastomosis has got adequate perfusion, ensuring that this may not leak in the postoperative period, at least because of the perfusion. That's this again showing similar thing that you can always do it in open surgery as well, but in endoscopic, in laparoscopic, or in robotic surgery, easily done by injecting the ICG, which can be given in a dosage of anywhere between 0.5 to 1 milligram per kg body weight. Uh, it comes in a vial of about 25 ml, which I just showed. 25 milligram, which needs to be dissolved in about 10 ml. So 1 ml equal to 2.5 milligram. You can give anywhere between 3 to 5 ml and then see the perfusion. Again, you can always do the immunofluorescence right after the anastomosis as well. So this is immunofluorescence being done right after the anastomosis, where you see an excellent blood supply on the descending colon and then on the rectum as well, ensuring that this would have lesser chances for a leak, and obviously has much better outcomes. Like I said, the telescope needs to be about 5 to 10 centimeters away from the target organ, and it needs to be seen. If you can see the perfusion within 40 to 50 seconds, you feel that the perfusion is absolutely adequate. But for colon, you can see even up to 3 to 5 minutes. It becomes a lot easier in robotic surgery, where we use the Firefly, similar technique, but very easy to move from a white light to immunofluorescence, and you can see the site where the perfusion is adequate, do a resection at that level, and the anastomosis, and there are lesser chances that this patient would have a leak. A leak of a colorectal or a coloanal anastomosis, one of the most dreaded complications after a rectal surgery, is associated with increased morbidity and mortality, and of course, poor oncological outcomes as well. Risk of a definitive stoma obviously stays, and which is for the rescue of the anastomosis, and it impairs the quality of life. In rectal surgery, anastomotic leaks can happen anywhere up to 19%, which I also mentioned earlier as well. And if we actually compare with patients who've had no leak versus leak, this was an excellent publication which showed that clinical and economic burden of a leak, and increases the hospital stay, increases the reoperation rate, increases the readmission rates, and it is all statistically significant, and overall reduction in quality of life, and increases the mortality as well. If we look at the role in colon surgery, this was a randomized clinical trial published this year, and this was an ICG colorectal study of nearly 1,100 patients, similar number of patients head to head in each arm. And this was a study between September 1st to December 31st, where half of the patients were given ICG and the other half didn't have an ICG. They excluded low anterior resection. So rectal surgery, left-sided colons were, left-sided surgery operations were excluded. It was only the other procedures, the right-sided, the transverse colectomies, which were included. But they actually concluded that notes ICG did not significantly reduce the overall anastomotic leak rates in laparoscopic colorectal surgery, but then they excluded the low anterior dissections as well as the left-sided operations. But in other surgeries, they didn't find any particular benefit. When we look at just the rectal surgery, and this was an excellent data, this was only in rectal surgery, and they went through all the studies, and this was a systematic review and meta-analysis, and they found at the end of, with comparing all these studies, it was statistically less in ones where the ICG was given. So lesser leaks of 4.2% vis-a-vis 11.3% where the ICG was not given. So we know the leaks can happen anywhere up to 19%. So if we could decrease that to 4.2%, and with experience, you can probably decrease it further. But getting down to 4.2% after giving an ICG was significantly better as compared to the ones where ICG was not given. Again, an excellent meta-analysis where the dosage which was given was anywhere between 0.2 to 0.5, mostly about 8 to 10 milligrams of ICG. So that is roughly about 3 to 4 ml. Now, what it showed was there was an overall reduction in leak rates by nearly 5 to 15% or 5 to 19%. But more importantly, in certain cases, they changed the surgical plan or the surgical site of resection. So they found that in 16.4%, they changed the surgical plan. This was a 19%, they changed the area of resection. So it went more proximal, ensuring there were lesser leaks. So again, becomes important, particularly in rectal cancers. So, so that's all about the the outcomes regarding anastomotic leaks. It also has advantages in avoiding ureteral injuries. Now, ureteral injuries, we know iatrogenic ureteral injuries can be there in pelvic surgeries anywhere between 0.3 to 1.5%. And number of ureteral injuries, of course, have increased with the advent more of laparoscopy. These injuries have increased, and how we can avoid them by using ICG. We would initially be using these colored stents. So these colored stents were a bit cumbersome. This was infrared illuminating stents, which we would be using. And this would take a little more time because we would need to do a ureteric catheterization and leave the stents in place. This is one of our, one of the cases that we were doing, and low anterior resection. And what we see is this, the illuminating stent is there. You can avoid the ureteral injuries, but then it was a bit cumbersome. Like I said, it would keep sparking all through the procedure, but at the same time, it required more time. And once we did the resection, you could see that the stents are there in place, and it ensures that the ureters are completely identified and lesser chances that you would have ureteral injuries. But we moved on. We moved on to using ICG. Now, how you can use ICG, the dose which has been recommended and which we generally use is 5 milligram. So 5 milligram, which would be about 2 ml. So 1 ml is equal to 2.5 milligrams. So we would be, so 5 ml, in fact, 5 ml needs to be used in each of the ureters. So you put in a ureteric catheter, and you go and you start putting the dye and keep withdrawing the ureteral catheter. And in fact, once you inject about 5 ml, it can stay for nearly 6 to 8 hours. Even surgical procedures which last 6 to 8 hours, you can easily identify the ureters, and it's absolutely safe. And in this robotic surgery, you can easily see that the ureters are clearly delineated, thus avoiding ureteral injuries. So this is again another advantage of an ICG, where you can avoid ureteral injuries by injecting this. So 5 ml each ureter. Uh, Average time which takes to inject this is anywhere between 8 to 11 minutes. So that is what the study says. That's what we take normally, 8 to 11 minutes. And most of us can do a ureteric catheterization. So it's easier to do. We don't really require a urologist to do this for us. Uh, the third and important clinical application of an ICG in colorectal surgery is lymphatic assessment, which is a cornerstone of a definitive surgical resection for colorectal cancer. Peritumoral submucosal injection of indocyanine green can be done. Now, what is an adequate time when it should be done? Uh, Publications say differently. Some say it should be done only 45 to 60 minutes prior to the surgery, but most say that you can do it 16 to 18 hours prior to the surgery. So colonoscopy, injecting submucosally 16 to 18 hours prior to the surgery, and you can continue doing the surgery 16 to 18 hours later, and it can actually identify the sentinel lymph node. And also, it has been seen that the harvest of lymph nodes is a lot better. The outcomes are a lot better after injecting it submucosally. So finally, friends, in conclusions, anastomotic leaks increases the cost, length of stay, significantly increases the readmission rates, overall cost, and 30-day morbidity and mortality. Uh, Immunofluorescence assessment of the bowel perfusion can assure a rapid and reliable anastomosis during a total laparoscopic colectomy. Well, some data in 2025 says that it's equivocal. Most studies probably are required to suggest that it is good in colonic surgery. Rectal surgery, there is enough data to support it. Potential reduction in the rates of AL in individuals undergoing resection cancer rectum, and particularly it's independent for gender, age, BMI, and anastomotic distance from the anal border, which is extremely important. Uh, it can be done for identifying mesocolic lymph nodes as well as the sentinel lymph nodes. But the data as on today shows that ureteric identification, lymphatic mapping, and assessing liver and peritoneal metastasis still remains in the more developmental stage, though I personally feel ureteric identification is pretty good. Further prospective randomized controlled trials are required, larger sample size is required, and longer follow-up to suggest that it is a standard of care. Thank you very much. And like Anil Arur said, and I would say the same, I welcome you all to the IAGS ELSA, which is happening in 13th to 15th of February. And ALS GBI is a part of and a collaborative society. And I welcome you all. It is going to be a grand event. And I'm sure we'll be happy to see you all. Thank you so much.
Thank you, Randeep. I think there is a large contingency coming from ALS-GBA. They have a separate session in one of the halls, as Raman Goyal said. So it'll be wonderful to meet them all in person. It's really wonderful to listen to you and with all the practical importance. Just I wanted to ask from one question from the query from one of the the audience, and also from me regarding the you are using ICG more recently, but we have been testing the anastomosis clinically most of the time. What is the discordance rate when you compare the clinically? You decide at what level I'm going to resect it there, but you do ICG. In how many cases you have to change the level of resection after using the ICG routinely, Randeep?
So what we've seen, Dr. Ishwar, in our own practical experience, in about 10% cases, 10 to 15%, where we feel that we'd had to change the level of resection. We've had to do that. What we've actually seen is that that's what the data, in fact, mentions as well. That if you actually see the perfusion, let's say a little later, you might actually get the telescope closer and you can see the perfusion maybe after a minute or 2 minutes. That still is a debatable area. But if you actually see a good perfusion at the end of 45 seconds and at a distance of 10 centimeters, you say that area is absolutely well perfused. Anything beyond that, it's kind of a debatable, and you would prefer to resect that area and go with an area which is completely well perfused and perfused early.
Yeah, thank you. I think during the open aero, we were very more comfortable clinically assessed by feel for the pulsations, and also even if there's a little doubt, we always trim the edges to see any mucosal bleed. But those things are probably less common in the era of laparoscopy, so that may be the reason. And the other thing I wanted is, when you rely on ICG, is it a quantitative or qualitative? For example, is it ICG good perfusion or no perfusion, or in between there is a minimal perfusion? What did you do? Is there any way, either you clinically or by AI means, can you say beyond this perfusion we can jolly well leave this at this restriction? What is the criteria you use?
So my criteria is timing of the perfusion. So if the timing of the perfusion is quick, if we can see the perfusion early, and I would say quantitative, it all shows green spark. And if you actually get the telescope nearer, the ones which are equivocal would also will also show green color. That's kind of equivocal. If you want better outcomes, then you need to keep it at a distance and just stay there and wait for about a minute. At best you can stretch it. So they have graded that, graded grade 1 to 4, something which you can see the green color or the perfusion in less than 20 seconds, well perfused. 45 seconds, it's grade 2. Then you move from 40 to 60 seconds, and then some you see after 60 seconds. So the ones which you see after 60 seconds are kind of equivocal. Those are the ones you'll probably like to omit. You might just stay up to uh, grade 3, which is up to 60 seconds, and not go beyond that.
Thank you, thank you. And you said its importance not only there, also in ureter and also in the lymph nodes. Is there any evidence or any literature about the bladder? If there is a difficult bladder resection, low down, anteriorly infiltrating tumor, whether the bladder can be visualized better by giving an ICG there, or anything you have done?
Great question, Dr. Ishwar. And I had actually presented something like this in World Congress, which both of us were there. So what we did was, we were doing a revisional, a recurrent groin hernia. Okay, so we were doing a recurrent groin hernia, and recurrent where there are posterior repair had already been done, and we were doing a revisional posterior repair. So I put in almost to the tune of filled up the bladder completely with ICG. Of course, ICG was about 5 ml, and then put in 100 ml and filled it. We could not see the bladder. The green color was not visible. So I concluded that it cannot be seen. Then I went and checked in the literature as well. So no visualization of the urinary bladder. But ureter, if you actually see all the data, it says even up to 6 to 8 hours. So there were some procedures which were done up to 8 hours, and they could still visualize the ureter. And the dosage is 5 ml. So 5 ml is what you need to inject. So 5 ml, so 1 ml is 2.5 milligram. So it becomes 12.5 milligram. That's a pretty high dose, but that's the dose which is required. That's the dose we've been giving. So that means a full vial, which we divide into, which we dilute with 10 ml. So the whole vial will go into half in one ureter, half in the other ureter. So we have to be putting in, and we put the ureteric catheter right to the top, and then keep injecting and keep withdrawing the ureter. And it stays there for 6 to 8 hours.
Thank you, Randeep. I think we'll go back to our colleagues from UK. Any questions from you, Safek?
Yes, thank you very much, Dr. Randeep. Amazing presentation. So my question is about the clearance of ICG. It's cleared from the kidneys, isn't it? It's a renal sort of excretion. So do you think that when we give, because it's also when they are trying to map out liver mets and so on, they give ICG like the day before or 24 or 48 hours before, so that it will accumulate in the liver. Does something similar happen in the bladder? Does it ever happen that at one point in time all the ICG is actually sitting in the bladder, and the bladder will glow? Is there any such studies or not really?
No studies as such, at least not that I came across any study which actually showed that everything kind of accumulates in the bladder. But yeah, you're absolutely right. If you would like to see the biliary tract, then you would need to inject it. If you just want to see the extrahepatic biliary tract, then it needs to be given at least 6 to 8 hours prior. That's the ideal time. But generally, like in all our biliary tract surgeries, we would be giving at the time of induction. where the liver as well as the extrahepatic biliary tract, everything is seen. Yeah, so 6 to 8 hours is what is ideal for biliary tract, yes.
Thanks. So, Dr. Iswarmurthy, are we happy to progress to the next
Yeah,
stage, if that's
yeah.
okay?
Please go ahead.
That's lovely. Right. So after two amazing talks, I think we have two more equally amazing talks. So it's with great pleasure that I invite Miss Marina Yasimedou, who's a consultant colorectal surgeon at the Royal London Hospital, which is the Barts NHS Trust, and an honorary clinical lecturer with Queen Mary University in London. Her subspecialist interests include colorectal cancer, pelvic floor, and abdominal wall reconstruction. She serves on the research committee of the European Association of Endoscopic Surgery and is a director of audit with the ALRS GBI. She's also a member of the EAES and the Society of American Gastrointestinal and Endoscopic Surgeons, which is SAGES, jointly sort of working in the sustainability working group, as well as the British Hernia Society. And she's an associate editorial member for BJS and BJS Open and serves as associate editor for Frontiers in Surgery and Scientific Reports. She's widely published with research interests encompassing surgical education, sustainable healthcare practices, assessment and optimization of clinical outcomes in colorectal surgery. But most importantly, she and I were colleagues. She was like 2 or 3 years junior when we were enduring the anastomotic leaks at Leeds. And we had a rich learning experience together, Marina. So welcome to you and thank you very much.
Thank you very much, Shafaq, for the introduction. Thank you to both of the societies for the invitation to talk here today. I will try and cover the huge topic of anastomotic leak and some evidence-based techniques for prevention as best as I can. So as a surgical society, for many years, we struggled to find a definition for anastomotic leak. And lots of societies had a go to define it. However, in my experience, the most widely used definition is the one from the International Study Group of Rectal Cancer. And even though, as implied in the name, it was designed for rectal cancer, I think that is widely used for any anastomotic leak in colorectal surgery. The reason for that is because it gives us a very clear definition, but also it grades the anastomotic leaks to a grade A that doesn't change the post-operative course of the patient, and to B and C where there is a change in the post-operative course, with B being a therapeutic intervention and C being the more catastrophic scenario where the patient has to return to theater for formation of stoma. Why is anastomotic leak so important? Because it's a relatively high incidence occurrence, and the sequelae for our patients can be very detrimental with severe morbidity, but also mortality rates that can reach up to 1 in 3 patients. We focus on quality of life indexes lately, and very rightfully so, and we can see that anastomotic leak has a very severe and prolonged negative impact on quality of life of our patients. And that is true for patients that had their ileostomy reversed and they didn't, and they were treated conservatively at the immediate post-operative stage. We can see that 12 months after their surgery, they're still describing a poorer quality of life compared to the patients that had surgery and didn't experience an anastomotic leak. There is also strong indications that it causes them to be, that it has an impact on their mental health and on their self-perception, according to the quality of life questionnaires that assess that. A lot of societies have tried to address anastomotic leak. I'm going to be focusing today on the COREAL project. I was very lucky to be a part of it, and so was Professor Salvasaker, and I'm sure many others on this call. The reason why it's so important is because they have a very robust methodology, which started with expert group creation that defined all the research questions, and then was followed up by a literature search and a major consensus meeting in Boston last year that was supported by at least 4 colorectal and endoscopic societies. They've divided the risk factors to preoperative risk factors, intraoperative, and postoperative risk factors. And for the preoperative, they've divided them to modifiable and non-modifiable. And I think it will come to no surprise to anyone that obese patients with bulkier tumors that are further lower down and had complications or neoadjuvant chemotherapy are in higher risk of forming an anastomotic leak. In regards to reduction of the risk, giving our patients antibiotics with mechanical bowel prep is essentially prophylactic. Bowel prep by itself probably doesn't work, and pre and post-operative probiotics don't work either. Or there's not sufficient evidence to say that they do work. In terms of intraoperative factors, we have technical things such as high IMA ligation. It might be a risk factor for that. Firing more than one stable also is a potential risk factor, and conversion from laparoscopic to open is also a risk factor. Prophylactic factors, those could be that could decrease the anastomotic leak, is the use of ICG and looking for the integrity of the anastomosis during the operation with either an air leak test or endoscopy. Of course, if we form a stoma that diverts the fecal, that provides fecal diversion, then you have not reduction of the incidence, but reduction of severity. Then we have the factors that make no difference, such as the routine splenic flexion mobilization, performing either open or laparoscopic surgery makes no difference according to what we found. Performing intraoperative endoscopy or leak test, if you perform one of the two, it's preventative, but it doesn't matter which choice you make, essentially. Reinforcing the stable line doesn't really seem to help, and using a pelvic drain, as we know, doesn't help either. So post-operatively, while we said that ERAS helps with a lot of things, it doesn't seem to reduce the risk of anastomotic leak. Short-term of non-steroidals doesn't seem to impact the anastomotic leak. Serial CRP is very promising. It's non-diagnostic, but also has a strong negative predictive value for excluding anastomotic leak. And in terms of diagnostic, a CT scan is more accurate, or endoscopy compared to water-soluble enema. In regards to treatment, if your patient is hemodynamically stable, then you can do a laparoscopic approach or an endoscopic approach to try and salvage your anastomosis. So moving on to strategies for prevention, we spoke about ICG. We had the INTACT trial that was spearheaded by one of mine and Shafak's previous mentors that concluded in 2024 from 28 specialized centers in Europe, included 766 patients with the primary endpoint being clinical anastomotic leak, with looking at grade B and C. Essentially, as seen here, they found no difference between either a clinically significant anastomotic leak between the ICG group and the routine care group, and they didn't find any difference in overall anastomotic leak between the two groups. What they did find, and it was mentioned by one of the previous presenters, is that there was a significant change in the plan anastomosis with the ICG group. Presenters. Conversely, the Japanese have done a very similar trial, the Essential trial, that again looked at rectal cancer with cancer less than 12 centimeters from the anal verge. They've recruited more patients than the Intact trial, 850. And they had their time point of assessment at 60 seconds and a slightly different protocol of giving ICG than the Intact trial. They have actually found that there was a significant difference for the overall anastomotic leak, which was reduced in the ICG group compared to routine practice. And also the clinically significant anastomotic leak was reduced in the ICG group compared to the routine practice. And very importantly, the people that returned to theater were far less in the ICG group compared to routine practice. In regards to bowel perfusion, the technology has progressed, and therefore there are a lot of other bowel perfusion assessment methods, and there was a systematic review and meta-analysis that it was published in the British Journal of Surgery in 2023 that looked at randomized control trials and comparative studies. They've identified 66 studies that showed different modalities of assessing bowel perfusion. As we can see here, the ICG is the most used modality, as we all know, and that's why we have much more availability of devices to use it, and also the product is much more available to surgeons worldwide. However, we do lack an objective marker of looking at the perfusion of the bowel, and we don't have any standardization in regards to protocol on the dosage and the chronicity on when to look at the perfusion of the bowel. There are several other methods that are used. They give more of a quantitative value of the bowel perfusion, but there are technical difficulties there. And as noted by the authors on this systematic review, we do not have as many studies looking at these other modalities as we have for ICG. Nevertheless, all methods that were seen that were assessed for assessment of perfusion of the bowel in this meta-analysis have shown a reduction in anastomotic leak when compared to routine practice. But as you can see from this table, there was significant heterogeneity in the studies that were included here. Moving on to newer methods, they're intraluminal bypass devices. Those are either biodegradable or ones that remain within the bowel and they have to be removed endoscopically. And they've been looked at by a systematic review in the International Journal of Colorectal Disease. Several devices there, with the Colovac being a non-biodegradable option where you have to remove endoscopically in about 10 days' time, and either biodegradable options that stay within the bowel and they don't have to be removed, they're absorbed by the body. So just to give you an indication of what happens, there is a placement of sheath within the bowel, and all the idea of it is all the fecal contents to go through that sheath and not to come into contact with the anastomosis until it actually heals. So this is placed at the time of surgery and removed 10 days after. You also have the biodegradable options like the leak guard that you can see here applied within porcine bowel. And then we can see that in the picture on the right hand of the screen is completely biodegradable, and in repeat endoscopy you can no longer see it because it's been absorbed within the body. There are also the compression anastomosis devices that use either a magnetic mechanism or a compression mechanism to compress the two parts of the bowel together until they necrose and they slough off to create the anastomosis. And the more modern techniques where you have, for example, the C-Rex, where you have built-in catheters that exit anally and they measure the anastomotic contact pressure, as well as allow you to give contrast if you are suspecting leak. In regards to other technologies, there of course the mechanical extraluminal sealants. This is one of the papers on CLG which I use in my own practice. They've recently a group recently published an observational study with 160 patients that included colonic carcinoma only. with a leak rate of 3.1 and return to theater of 0.6. So this is one of my videos. That's how the anastomotic glue is applied. So it's just to reiterate that it's not a substitute of the sutures or of the stapling line. It's just an external reinforcement of the anastomosis. Then we move on to biomarkers for early detection of anastomotic leak. There was again a systematic review that identified 20 studies, and they include both right, left, and anterior resections in this. And we can see that CRP is a promising studied biomarker, and is promising because we know we have specific cutoffs that in studies they vary between 140 to 190, and we have a specific time frame where the CRP can be measured at day 3. We also have procalcitonin that it is actually a promising biomarker. However, the cutoff rate is not as straightforward or as defined as with CRP, and we also don't know if we need to measure it at day 3 or day 5. The white cell count is very limited as a standalone marker, and we have, and I'll talk about it a little bit later, peritoneal fluid markers that assess inflammation or CRP protocol, or even a combination of these markers, and there have been promising evidence, promising emerging evidence on these markers as well. Again, in regards to early detection, there is a launch of a new study. They've published their protocol, whereby this is for rectal cancer mainly, whereby they use a bedside system to monitor the anastomosis endoscopically. In regards to emerging technology, and you'll be glad to know that this is my last slide, there are novel intra-abdominal sensors, as I mentioned before, with the biomarkers, and some of them change the peri-anastomotic environment, the change of impedance or the change of acidity. This is a continuous monitoring that is meant to detect anastomotic leak early, but of course, again, similarly, to the ICG, we don't really know what the cutoff points are, and we don't really know which is the best time to actually measure this. The other thing to note is that anastomotic leak lends itself quite nicely to machine learning because it is multifactorial and is relatively low incidence. So it requires looking into large databases to be predicted accurately, and machine learning can analyze much faster and much quicker than humans can those large databases. Thank you, and I'll take any questions if you have them.
Thank you, Marina. Sorry, I'm struggling a little with my camera. There we go. Amazing talk, and in great detail over there. Very refreshing to see all the emerging technologies. Obviously, we're not going to put this to bed until we found a solution, haven't we? So with this, I think what we will do is we will go on to the next talk and then take the Q&A all together at the end. So it's with great pleasure that I am able to invite Mr. Mithane Patel, who's a senior clinical fellow in colorectal surgery at the Royal London Hospital. He completed his Master of Medicine in General Surgery at the Aga Khan University, East Africa, and has held consultant and leadership positions across East Africa. His clinical interests include colorectal and general surgery with a focus on MIS techniques and surgical critical care. He's contributed to international research and is committed to advancing surgical training and fostering global collaboration in surgery. So great pleasure, Mithane, and looking forward to hearing your talk. Thank you very much. You're muted, Mithane.
Thank you for the lovely introduction. I'd like to present a case report and to see what can be done to prevent it. So it's essentially just practical lessons using a clinical case. And again, most of the evidence-based prevention strategies have been discussed in good details by my colleagues earlier. So I'd like to introduce a 62 years old gentleman who presented with recurrent full thickness rectal prolapse. He had previous mesh repair, posterior rectopexy 1 year prior. His medical history was just significant for hypertension and dyslipidemia. He had a BMI of 28.7. Now, multiple treatment options were discussed with this patient. These included resection rectopexy, redo mesh rectopexy, or suture rectopexy. And further to the conversation, the conclusion was to proceed with the resection rectopexy. Sorry. Yeah. So intraoperatively, he had a loose patulous anus with about 7 centimeters of full thickness rectal prolapse. He had quite inflammatory and excoriated rectal mucosa and a significantly redundant sigmoid colon, quite a bit of fatty mesosigmoid and mesorectum. He underwent a laparoscopic resection rectopexy with an end-to-end colorectal anastomosis using a 33 CDH. Intraoperatively, unfortunately, there was no ICG done at that time. However, they did confirm 2 intact donuts, which were obtained and visualized. We also did an air leak test, which was negative for any leak. Post-op day 1, he was doing quite well, except for some nausea and vomiting, which settled down with some antiemetics. And by day 3, he developed low back pain and rising CRP. His white cell was otherwise downwards trending, and he had some generalized abdominal tenderness, though it wasn't particularly concerning at that time. So the team decided to sit on it. And the next day, this was post-op day 4, he started getting rather unwell with a rising CRP, which was now 400, and his white cell was also rising to 16. So we recommended a CT scan, which now confirmed a rectal anastomotic leak with significant pneumoperitoneum. And these are his images, and as you can see, there was quite a bit of free air in the abdomen and contrast extravasation from the rectum. Following this CT, he underwent laparotomy, washout, and the loop ileostomy was done. He with drainage. There was only 4-quadrant purulent peritonitis, so the plan was just to wash out. Following this surgery, for the first, it took him about 22 days to recover from the surgery until he was eventually stepped down from the HDU. His drains came out by day 7. However, he did require prolonged course of antibiotics and TPN. He had a repeat CT scan on post-op day 22. This is following the second surgery. This confirmed that there was still some localized cavity in the posterior to the rectal anastomosis, but the new peritoneum had resolved, and clinically he was doing quite well. He stayed in for another week or so until his package of care and everything was sorted, and he was well. He was able to cope on his own. So, reflecting back on this, we wanted to see what could have been done better. And I think a few points that came to my mind was one, we could have done pre-op bowel prep with antibiotics, and there is good evidence body to show the benefits of this. Intraoperatively, use of ICG, and post-op on day 3 when his CRP did shoot up, should we have done a CT scan at that point? And I think a lot of evidence for all this has already been discussed. There was a mobile trial that was done in Finland. It was a multi-center trial, and that shows that there is significant benefits of pre-operative mechanical bowel preparation and oral antibiotics for colorectal surgery. And while they looked at the benefits it surgical site infections. There was a significantly reduced rate in that. It also shows that there is a significant improvement in anastomotic adhesions as well in patients undergoing elective surgery. The other thing was the ICG, and I think my colleagues have already spoken about the INTEX trial, and this has also shown that there is significant benefit of ICG, but it's mostly towards grade A and B leaks. In terms of grade C leaks, the rates were quite similar in use of ICG or not. And the other thing was the predictive biomarkers on day 3. CRP, white cell count, and procalcitonin were all looked at in this interesting study by Dost et al. And in this systematic review. And CRP has been shown to have a very strong sensitivity and specificity of almost 80% and a negative predictive value of 95%. While it does not directly hit towards an anastomotic leak, it does warrant further investigation to rule one out. And I think in this patient, it was quite more than likely indicated that we could have investigated him on day 3, and it may have changed his outcome. Thank you.
Very much. Thank you very much, Mithane, for that case presentation. And yes, I kind of agree with you about the CRP. And when we were kind of leading the PREDICT study with the Australian colleagues, one of the things that we demonstrated is that the CRP more than 127 on post-op day 3 is almost predictive of an anastomotic leak, and actually shortens your detection of the leak and the sequelae from it by at least 24 hours, if not longer. But having said that, I suffered my first anastomotic leak of the year last week. I was speaking to Marina about this earlier before the webinar started, and unfortunately we waited until day 4 because we thought the patient was opening her bowels. She'd had 2 bowel motions, had a bowel motion on day 4, and we were getting a CT scan simply for a chest infection, and it turned out she had an anastomotic leak as well. But we'll go into that conversation a little bit later. Right, so we have a lot of questions, and clearly that's a good sign of engagement because the subject is just so very interesting. And I think what we will have to do is to take the themes of discussion rather than, take each question, because that'll be a bit counterintuitive. So while we are at it, let's talk about the value of CRP. I mean, how many of us are using CRP as a predictive biomarker in our day-to-day practice? I mean, I just gave my disclaimer over there, how we goofed up. Marina, any comments about that?
Yeah, I think I think it's a very promising predictive biomarker, especially in regards to the negative predictive value. So if you have a CRP that is below 100 or is low, then you can be reassured. The other way around, even though it's not diagnostic, if you have a persistently high CRP, especially after post-operative day 3, I think that you need to start thinking. And I mean, we all we're a little bit in denial when it comes to anastomotic leak. Hence this case that Mithane has presented. Potentially, we could have imaged a day before based on the CRP. But I think if you do have a persistently high CRP after day 3, you should start thinking that unfortunately an adverse event and specifically an anastomotic leak has taken place.
Yeah, it's an anastomotic leak until you can prove otherwise, isn't it? Let's hear from Dr. Anil. Thank you for joining us live, and we really enjoyed your talk earlier on, Dr. Anil. What's the practice in India with respect to using, CRP?
So I would agree with Marina there. Apologies for joining late. I was on a flight and just got delayed. Thank you for appreciating the talk. So as far as CRP is concerned, yes, we do it routinely, but we have made the same mistakes sometimes, in spite of the CRP rising, we tend to wait for a rise in counts, which sometimes, as we all know, the WBC count actually starts going down. That sometimes presents a problem because we are so used to taking the white cell count as something which is standard, so to say, because we have been trained that way. But uh, the evidence that we are now hearing, as Marina so excellently presented, is I think we need to rely on CRP more.
And there is this feeling as well, isn't it, that the CRP is always on a lag. It's always on a 24, 48-hour lag. So that can be a little bit misleading sometimes. So let's go on to the next question again. To all members of the panel here, because all of us will have had this experience. Is this just anecdote, or is there actually evidence about the difference in the anastomotic leak rates between laparoscopic and robotic surgery? I mean, industry will have us believe that it is a lower leak rate, but what's the experience? Let's start again, I think, with Marina, because she's unmuted herself.
So, basically, we have, as part of the Coriel group, has actually looked into that, and currently, despite what we anecdotally may or may not believe, there is no evidence to support that there is a difference in anastomotic leak, specifically in rectal cancer surgery, between a robotic and a laparoscopic approach. If you speak to experts, especially there is a specific expert in the UK that swears that, and I can see his point in the sense that you do have better visualization, better planes, probably a less traumatic dissection that you would have with laparoscopic surgery. But at the moment, I personally, in my opinion, I don't think that we have sufficient evidence to say that there is a significant difference in anastomotic leak between robotic and laparoscopic surgery.
And across the pond from Dr. Anil, what's your experience in this space? Do you think that there is a difference, or you think that there isn't?
No, the short answer is no. I don't think there is a difference. I think anastomotic leaks remain multifactorial, and I don't think the approach is going to make so much of a difference as far as leaks.
Yeah, I would agree with that. I think the whole it depends where the anastomosis is as well, I believe, because the right-sided anastomosis on the robotic platforms are massively different to how you would be doing them laparoscopically. So there's less handling and a much more precise joint, which is isoperistaltic and so on and so forth. But I think the left-sided anastomosis have changed very little, regardless of what technology we are utilizing. So it would be nice, to see a difference there. But people tend to lump all their anastomosis together in one basket and then lower the leak rate that way. That's one technique of lowering your leak rate. So with that said, I mean, when would we decide? So we have a leak. We have this patient, unfortunate one, who has a leak. When would we decide to salvage a leak as opposed to just dismantle it and just live to fight another day? Let's go to Dr. Anil, with that one first.
I just missed the last part of the question. What was it?
So you have a leak now. Patient has leaked. Unfortunately, it's a rectal anastomosis. It has leaked. When would you decide, or what influences your decision making in terms of I need to take this leak apart, or rather I'll need to take this joint apart, or I'm just going to defunction this and try to salvage this joint? What will be the factors that will influence that decision?
So the first factor would be clinical. How is the patient behaving? If I'm going to explore the status of the intraoperative findings are going to influence me. If there are stools lying, if there is a lot of contamination that has occurred, I would rather take down the leak, do a Hartmann's, and live to fight another day. But however, if it's a small leak, it's a repairable leak, I would repair it, defunction it, give a thorough wash, and then wait and watch what happens. So I'm not really very hasty on trying to take down the anastomosis. I would depend heavily on what the clinical findings are.
Thank you. And I'll bring in Graham because we'll want to learn from Graham's experience on this. And what's your decision-making strategy, Graham, if this happens?
Well, I would essentially agree with Anil. It depends entirely on the general status of the patient. I would also bring in the site of the anastomosis. I'm firmly convinced that if you've got something low in the rectum, salvage of that anastomosis is a little more difficult than if it was higher and out of the pelvis. Obviously, we want to have one chance at things. I believe that the older the patient is, the less of a chance they have if you try and salvage it. So I would tend to go for bring out a Hartmann's for left side. I feel that there's a lot of discussion about defunctioning. Now, if you're trying to defunction anastomosis in the left side, there is still a colon full of feces. It's got to leak out to the anastomosis whether you defunction or not. And I've had problems by saying, right, we'll just defunction, but the remainder of the remnants of the feces in the left colon have created nuisance. So it is multifactorial. Condition of the patient. Albumin is certainly one of my considerations. It was mentioned earlier on in the talks, low albumin, be very careful. It actually increases the chance of an anastomotic leak. It also increases the chance of disaster if you try and salvage a leak. And that's about all I've got to say, Shafiq.
Thank you for
Okay.
that.
Good.
Thank you very much for that, Graham. I'd agree with that. I think the stool in the left side, especially with ERAs, we want to feed them quickly, and doesn't matter what bowel prep you've given them. I think it does get in the way unless you have also defunctioned them at the primary operation. Marina, your comments on that? And tell us a little bit about endosponge and the fasting, because we had a lot of experience with endosponge in Leeds, didn't we? Because we were really salvaging them and changing them every 3 days. So tell us a little bit about that in your practice.
So I don't currently use endosponge, if I'm honest. In regards to the leak, I mean, there are some straightforward cases when you have a hemodynamically unstable or septic patient, or if you do a laparoscopy and you have fecal contamination. Those are the straightforward ones. That's, in my opinion, an anastomosis you cannot salvage. And then it depends, as Graham said, on the patient, like the comorbidities of the patient, how well they will cope with an anastomosis that you're trying to salvage. For example, their comorbidities. We know about the risk factors of anastomotic leak. They're low albumin, diabetic, ASA more than 2. So it depends on the patient and depends on the anastomosis. Yes, I don't have any personal experience with endosponge. I know that people use it. I think that we see, in a sense, we see from our patients, and because we focus now on patient-reported outcomes, that even if you do have an anastomosis that you do manage to salvage, there is an impact on the quality of life. There is still increased discharge from the back passage and very poor function. And at the end of the day, whether you are successful in salvaging an anastomosis, you can see patients that are quite desperate to not have anastomosis salvaged because of the poor function that they're getting. So I guess it's a discussion, as everything, with the patient, and we should really try and take into consideration the quality of life and the patient wishes. I have a lady who is currently my patient, and she has been suffering with discharge, and she's quite desperate to not have that anastomosis salvaged. So essentially, yeah, it is a discussion with the patient.
And one of the other aspects is also the fact that if they were to require adjuvant chemotherapy for whatever reason, and you've got pelvic sepsis there that you're trying to salvage for an anastomosis, or you may be unsuccessful at salvaging the anastomosis, but you've left the patient with chronic pelvic sepsis, and you've kind of maybe almost denied them the option of getting adjuvant treatment, and that compromises their disease-free survival in a way as well. You know, that's one of the reasons why I've moved away from actually defunctioning patients primarily with an ileostomy. And essentially, if it leaks and it's so bad, I will just dismantle the anastomosis and give them a stoma and get them out of the pelvic sepsis quickly. Rather than actually defunctioning them. I see that Dr. Anil is raising his hand. He wants to contribute to that.
Yeah, thank you. So, sorry for interrupting in between. So I agree with Marina completely, and especially if it is an ISR or it's a very ultra low anastomosis that has leaked. My threshold for dismantling would be very, very low because the functional outcomes of that leak are going to be really, really poor. The patient has a bad last, they end up with a stricture, so the quality of life is extremely poor. So I would agree with that.
And there's another little challenge with those ultra low anastomosis. I remember once that we actually made a coloanal hand sewn anastomosis in a patient because the polyp was just so low and that leaked. And that was fine that it leaked, and we tried to manage it and salvage it. But the patient didn't want that anastomosis and he wanted something else. And we couldn't really easily bring out a defunctioning colostomy. But for us to dismantle, we can't leave a devascularized stump in the pelvis. So for you to actually dismantle it, you have to pretty much do an AP resection now to bring out a stoma, which makes everything so much more challenging in this subset of patients. So I'll bring in Professor Selvasekar with the Christie experience now in terms of what would you be doing in these kind of high risk irradiated patients and so on, and they've leaked.
Yeah, well, thanks very much. I know it's a fantastic webinar. It's good to see the practice in different parts of the world. I think we see lots of patients with post-radiotherapy. I agree with you, Shafaq. They are a different, the way we deal with them. It is not that dismantling the anastomosis, which is an issue, it's closing the rectal stump after that. It doesn't, it is rock hard. What we have done recently is put a Foley catheter in through the anus. And then you get these big 32 French Foley, which we used for bladder irrigation and things. We put them in, blow the balloon up, and then if you can get the momentum into the pelvis, get it into the pelvis so that that area is secure, and then a couple of drains, and then bring out an end stoma. I think we have tried. We have usually it is not that difficult to dismantle it, but if you divide the bowel slightly higher and things, absolutely you're right. That bit of bowel, what you have left behind, becomes a chronic necrotic abscess, and you don't know whether it is an abscess because of the leak and all the effects, or whether it's a bit of a dead residual proximal colon which is there. So but most of the time what we have found is that you can disrupt the anastomosis completely because it's already leaked and there's a lot of inflammation and things. It's always difficult to know when to take the patient. I think I can't remember whether it is Marina or you, Shafaq, where when you have clear-cut sort of patient unwell and feces and things, it makes it easy. But if it is not, if it is one of those things where there's a contained cavity, endosponge, I think it's an absolute nightmare, because we have one of our colleagues who came from London and he was very keen initially, but the anesthetist hated it. Because every few days we need to take the patient back to theatre, unlike practice in India where you probably would do a lot of these in the clinic or outpatient department. Here, the patients want everything under general anesthesia, and to get the theatre slots, it's absolutely difficult. Eventually, he has given up now. I think it is extreme, and I'm not sure how effective it is as well functionally, because it protects when Robin Kennedy and people like that initially was saying that it is useful and you can save the anastomosis, I think most of those anastomosis would have been saved anyway. Whereas a small percentage, I'm sure there is a benefit, but it is a long drawn process and functional outcome at that. Most of our patients are having radiotherapy anyway. Once they have an anastomotic leak, I think the function is gone. Basically, it just we have to be realistic, because if you do the if you ask for the patient reported outcome scores, LARS and things like that, I think it'll be bad. They will be leaking all the time, and most of them would prefer an end colostomy rather than a. And I would not recommend a loop ileostomy for someone who has got an anastomotic leak, because you are asking for trouble. I know that I've attended meetings in various places. I'm sure you guys all have, where people say, "Oh, just give a loop ileostomy, you'll be fine," and it may be fine because it would have been fine even without that. But if there is an anastomosis which is significant and there is a leak, then you're with the proximal colon loaded with feces. Because you've already heard that 1 in 3 can die. It is at the end of the day, the patient needs to be alive for us to, we can always fight another day in these situations. So get get a colostomy out, and then get the patient out safely, and then we can always revisit it depending upon what the needs are. I think it's been fantastic. Thanks very much. I've learned a lot with these ICGs and various newer biomarkers and things. Well done, very good, everyone. Thank you.
Thank you. Thank you very much for that. So I think before we draw to a close, there's just one little subject that we should just touch upon, and it's one of the questions as well, is the fact that we're all second victims of anastomotic leaks, aren't we, as surgeons? So would we kind of chicken out of this situation and consider not joining at all and just give stomas to all patients? I mean, that's an easy solution. So let's, Professor Selvasekar, what's your view?
Shafaq, you probably need to explain what a second victim is, because a lot of people may not know we hear that a lot in UK. It is a so it might be good if you can just explain what
Yes.
it is, please. Thanks.
So essentially, it's a concept, and I agree, it's an emerging concept where we say that the patient who has experienced the anastomotic leak is obviously suffering it, and it's not just suffering it physically but also emotionally. But the pieces of that experience are not just picked by the patient and their family alone. It's the surgeon who inflicted or allegedly inflicted the anastomotic leak on that patient by means of performing the operation in the first place. So we are also suffering, but we are suffering in silence. And therefore the term second victim has been coined. So every leak is a bit of a hit to the heart, so to speak, when it does happen. Like I was saying, I thought I was going to spend this year without a leak, but hey ho, last week I had one. So that's where you start questioning yourself and your sanity, and you're like, should I even be joining all of these ultra low resections that we perform? So Dr. Anil, what's your views from India? What would be the opinion on this?
No, I think it's the same everywhere. And just in the morning, we just touched upon this subject. I was in a training that there was a training meeting, and we just mentioned that whenever you have a leak, the next few weeks you are defunctioning more patients than you did before. And I think that's something that I think the term second victim is absolutely right. You lose years of your life once you have a leak, and you carry the guilt in your heart. But having said that, no, I don't think it comes to that, because you know that finally, when you come to terms with it, you know that this leak had a reason, and we go ahead and correct that reason, and we continue to function and try and avoid stomas wherever we can.
Fantastic. Crocodile skin for surgeons. Prof. Selvasekar, would you agree with that?
Yeah. But the thing is, at the end of the day, we all get complications. We need to have insight and always ask for help. If you have a patient, we are not sort of anymore who deal with it, and it's not always on our head. So if there is always these gray areas, ask for help. There's nothing wrong in that, because at the end of the day, the patient benefits from it, and that is what is needed. Our egos can always be, boosted up later.
Absolutely. And we will never deny a chance at a join for the 8 patients, because 2 of them out of 10 are going to end up miserably. So that's probably the other thing. I can see Marina smiling over there. I think we're coming to a close now. I think we've already kind of overstepped our time. So Kanageval, I think we're extremely grateful for all the organization and everything. And over to you for the closing. Is that okay with you?
Yep. We have the president waiting to give his comments, and then I will take a quick minute of all your time to regarding the announcement of the upcoming program for the January. So, President, I would like to give your comments, sir.
So it was a quite a learning symposium with a lot of new ideas. I know that still a lot of ice has to be cut for this problem. But anyway, it's a part of the game, and we have to keep on improving on this. So I thank all the speakers, moderators, and office bearers of uh, GBI. And this will be the last seminar of this year. So wish you all a very, very happy Christmas and New Year. So next year we will be meeting for our seminar in January. I think Dr. Kanak will give the information about it. And I hope to see a big contingent coming over for our IAGSL meeting. Thank you once again. Good day and good night.
Friends, it's been a pleasure to work with the British colleagues and then people who have joined now over the globe. This is the preliminary information for you to block your dates. It's going to be 17th January 2026. It will be on, this is a preliminary flyer, minimal invasive endocrine surgery. So we have a couple of speakers from India and a couple of speakers from United Kingdom. As of now, we have Dr. T. Shivakumar, our Honorary Secretary of the IAGS, will be speaking on peroral thyroidectomy. And Dr. Sanjay Mohanty will be speaking about cancer axillary thyroidectomies. And then from the speakers from the United Kingdom side, we have Mr. George from Highlands speaking about connecting the dots to pheochromocytoma. And then we have Mr. Sebastian from Aberdeen Royal Infirmary to speak about minimally invasive adrenal surgery. So with that, I thank all of you for joining today. We have more than 1,000 people joined in the platform, around 800, and then we have the Facebook Live and the YouTube channels of the IAGS. So thank you everyone for sparing your valuable time to be with us. And we had a lot of questions today also that shows the amount of commitment you have towards this program. So by January, we'll be, by the time the organizing team will work on a calendar so that over the period of the year, you'll know what are the programs, what are the subspecialty we are going to have, so that those who wish to contribute can reach either the United UK team or one of us from India if you wish to be part of this. We will work out something like we can have little more differential approach, few talks and probably a quick panel discussion, other things. Let us amongst the organizing team have a quick discussion about it, how we can improve the reach of this program, and then to give you more quality learning opportunities and then sharing opportunities should you wish to share any of your tough cases also. These are the things on annual. And on behalf of both the British colleagues and the Indian colleagues, I extend you advanced festivities for the upcoming Christmas, and we wish you a prosperous new year coming up. And once again, thank you, UK team and IGS team for allowing us to do this program on a continuous basis. Thank you very much. Good night and good evening. And once again, thank the DocPlexus team for providing a very stable platform for all of us. Thank you, DocPlexus team. Thank you, President, and good night, everyone.
Good night.
Thank you.